My name is Julia Jenkins, and I'm the Executive Director of the Every Life Foundation for Rare Diseases, dedicated to spurring biotech innovation for rare disease treatments. RDLA is a program of the foundation created to give rare disease patients a voice on Capitol Hill, and that's part of what we do here at the Caucus. I do want to thank our Caucus co-chairs, Representative Leonard Lance and Joe Crowley, for their continued dedications to give patients a permanent voice on Capitol Hill. We have 80 members now. We hope to grow that over the years. Before we get started, I want to thank our sponsors, BioMarin and Vertex, and our co-hosts, NORD and Leukemia and Lymphoma Society. Today's goal for the Caucus briefing is to show how the Affordable Care Act has affected the rare disease community. We have both positive and negative stories, as I'm sure all of you have heard both. So we want to make sure that Congress continues to hear from the rare disease community how this legislation has affected patients and how new legislation may be needed to improve access to care and treatments for rare disease patients. So we are going to start with Sandy Robinson from Avalier, who is going to present on their new report.
So thank you for the opportunity to be here today, and thank you to the sponsors. I wanted to give you a little bit about my background first, and then I'm going to talk about some studies that Avalier has done, some research that hopefully will be insightful today relative to the changing healthcare marketplace. So I've been in the healthcare environment for 25 years. Started my healthcare career on the payer side with a major Blue Cross Blue Shield plan, and then have been with a number of strategic advisory services firms over the last 22 years. And one of the things that I'm passionate about is patient access to medication. So very happy to be here today. I will tell you as a disclaimer that Avalier Health is not a lobbying firm. We are a strategic advisory services company. And what we do is produce a lot of research studies and use those insights for our clients. So what I'm going to show you today are some insights that come from two of the studies that we've done, both of which this information is in public domain. And I'm excited about the opportunity to share with you what we've done. So I'd like to start just with a broad stroke. So on the next slide, what you'll see, we like to think about the types of, we take everything that I'm going to talk about today is kind of taken from the patient's lens. And particularly to a rare disease patient with access issues that are even more complicated and also complex. So if you look at the first slide here, these are some of the key issues that patients face from an access perspective. I mean, to start with, obviously, premium affordability, and that's been something that has been raised even more so with the implementation of the Affordable Care Act and the marketplace exchanges that have come into play in this inaugural year. I'm going to show you a little bit of the data from that. The second, which is particularly of concern for rare disease patients, is narrowing provider networks. So not only from the perspective of the networks being narrow within exchanges as compared to commercial insurance, employer-sponsored insurance, but also the fact that in addition to that, many rare disease patients have to cross state lines in order to get access to the specialists that they need. So this is a really key concern for rare disease patients. Formulary breadth, and I will say I'm going to compare and contrast this as we get into the exchange marketplace information, but you've seen a lot in the press about access to actual specific information on whether my drug is covered or not. And we've had some challenges this year, and we're hoping to improve that going into the next calendar year. Utilization management, high-cost specialty drugs, and the definition of those differs, but for Medicare, which kind of sets a base, it's at $600 per month. And anything that's over that typically gets pushed up to the highest tiers, specialty tiers, on a plan's benefit structure. The challenge is that there's also utilization management. Now, plans use this in a way to actually control costs and have the least costly alternative that's provided. The reverse of that is that it presents another obstacle in the form of prior authorization, step therapy, quantity limits, et cetera, for the patient and the provider. So that's a real concern, another potential barrier. And then, of course, higher cost sharing. So what we're seeing is a lot of shift to co-insurance versus co-payment. And I know that there's going to be some other talks about that later today. And then the last is copay assistance, which is still an uncracked nut as we speak today as to whether brand-specific manufacturer-sponsored copay assistance programs are or are not allowed in the enrollees that are in the exchanges. So that's a question mark that continues to be a TBD. So I'm going to talk a little bit about our Planscape data. This is all in public domain, so I'm not going through anything that is related to, there we go. Okay, so I wanted to give you some idea how the exchange plans are comparing as a market segment relative to Medicare Part D plans and the employer-sponsored insurance, which is on the far right here. And as you can see, it's really interesting, but the complexion of exchange plans are looking more like Medicare Part D plans than they are employer-sponsored insurance. All of these are run by commercial insurers that are in the marketplace, and there have been some who have chosen to get into the exchange marketplace and some who have not. But what's fascinating is you can see 90% plus are using the highest tier levels, 4 or more tiers, which is the orange or the red there, relative to the employer-sponsored insurance, which is about 23%. So more tiers and higher tiers, particularly with specialty tier on the top, which translates into higher cost sharing for the patient, out-of-pocket costs because of a co-insurance versus a copay that's attached to that. On the next slide, thank you. So what we did is looked at utilization management to see what that looks like in the exchange marketplace. And you can see we have 3 categories here with mental health, oncology, and then HIV/AIDS. And you can see the utilization management, which again is that orange-red color. In the exchange, the comparison is much more severe in terms of utilization management that's applied versus employer-sponsored insurance. So you can see, for example, in oncology, a pretty significant difference there between 30 and 43%. On the right side, you can see that there's 6% for HIV/AIDS versus exchange of 21%. And I will say that a lot of this is due to a lot of the advocacy work that's been, dates back to the late 80s, early 90s around HIV/AIDS and access to medication. So that's why you're seeing sort of that smaller. This is also an area that's a disease management and case managed on the part of employer-sponsored insurers. So in spite of this, one of the other issues that we have that's a potential access barrier is provider access. So this is just a case study that we pulled for Los Angeles County, in which there are more than 28,000 licensed physicians in the county of Los Angeles. And you can see for California in Los Angeles County, those plans, commercial insurers that are participating in the exchange marketplace. So those are listed below. And you can see the number of physicians that they have in network. So this is, I think, a stark comparison to what we're looking at from Health Net being on the small end of 2,300 of those 28,000 that are licensed physicians, to Anthem on the high end that still has, almost nearly 9,000 of that pool of physicians that could potentially be in network, this 28,000. So this is a huge issue. This doesn't talk about, again, for rare disease patients, crossing state lines and the special considerations that are associated with that. So I want to shift a little bit now from exchange and the ACA to commercial payers and talk about another study. This is in public domain. This information is in public domain. It was just released at the AMCP, Academy of Managed Care Pharmacy. And this was a joint project that Avalere Health did, a study on behalf of Johnson & Johnson and Janssen Biotech, Inc. And it's really a forward-looking study. It's called Dimensions, and it's on specialty pharmaceutical trends. So this is the 2014 data that has just been released, I would say, because it's in public domain. So for 2014, what we did is said, we want to know as plans, and there were 81 plans that participated in this, we want to know what you're thinking about in terms of cost containment measures, both from a benefit design perspective and other techniques that you're using. So from the commercial plan perspective, they're really actively experimenting with anything that they can do. And I should stop and say that we're sort of at this really interesting crossroads within our healthcare landscape. We're expanding coverage, right? And so we have uninsured who are now being insured through Medicaid expansion and through the marketplace exchanges. But we also have dynamics in play that are causing us to bend the cost curve. We are expecting more quality and better patient outcomes for less cost. And so what happens is that we have these sort of opposing forces that are at play. So what the commercial payers are doing is looking for active ways and techniques and management that they can do to try to control the drug spend while also getting better patient outcomes. So in the top bar here, these are the 4 that ranked above 50% in the study. And below was just those that are also mentioned but are less than 50%. So if you see the top, the number one thing was drug waste mitigation, and I'm going to show you some statistics on that. And then SPP channel management, which is specialty pharmacy provider channel management. So dictating on the payer's behalf how prescribers or physicians, as well as physicians that are in any type of setting of care, and patients are getting access to specialty drugs. And what they're doing is dictating the channels. And then the innovative manufacturer contracts, some of us who have been in the industry this long might say there's not a lot of innovation or willingness on the part of payers to innovate, but we are seeing some of those trends. One of the interesting upticks has been in price control. So within the contract, payers are asking for a ceiling on the price increases that manufacturers can take, and that has caused a lot of controversy in the marketplace as well. And then site of care optimization, which I have some deep dive information on as well, and that is really the payer's desire to drive patients to the most appropriate setting of care while also controlling costs. And I don't know if anyone saw the IMS data that was released this morning on the differential between oncology care that's administered in the hospital versus the physician office setting. So those are the sort of the top 4, if you will, that plans are thinking about. They're either utilizing them now or they're thinking about doing these in the future. So on the next slide, again, from the same study, the Dimension study, I think this is fascinating, because on the left, you can see the drill down on drug waste mitigation, and it falls into 3 categories. One is drug reauthorization requirements that are being put in place, medication adherence programs, which we know to a great extent improve patient outcomes, and then partial fill programs, which are being used to split fills at a pharmacy so that if you start a patient on a medication and then the patient needs to change the dose, that you're not dispensing a 30-day supply and wasting whatever the amount is that's remaining in those 30 days. So I think what's fascinating, and we put little arrows in there, is that, for drug reauthorization, it's pretty static between the 4 areas that we looked at. And the therapy areas are on the top. So we looked at hepatitis C, RA, oncology, and MS. Why did we look at those? These are the key drivers, either have been or are expected to be based on pipeline products for specialty pharmaceutical drug spend. And this was confirmed from the 81 participants that were in this study. So if you can see medication adherence, you can see that the blue bar is really high. So on hepatitis C, it's 52% are anticipating using that versus those for the other 3 therapy areas. And then the partial fill program, you can see that the majority of that is done in oncology. And a lot of that has been based on oncologist feedback to how we need to manage medications and doses for patients. I can't expect that I'm going to dose for 30 days the same way. I'm going to adjust that dose as the patient progresses. And then in the center is SPP channel management. And you can see, again, pretty homogeneous in terms of across the 4 therapeutic areas. And then site of care optimization. So for each of these, there is sort of one that's either a little bit lower, a little bit higher. And so you can see for site of care through prior authorization and using prior authorization to control that. For MS is the lowest. You can see oncology is the highest bar there. And then doing site of care through cost sharing, so using cost sharing on the patient's part to encourage a particular incentive or disincentive to go to any site of care. You can see that oncology in this case is 30%, and the largest here is rheumatoid arthritis. And then for the last, you can see that oncology sticks out here with 44% of site of care through reimbursement, so differentiating reimbursement by site of care. So we find this fascinating because, again, this is forward thinking, so this is what payers are going to do in the future. So I just want to wrap up by saying that, a lot of people say, okay, we see what the potential patient access issues are, what the barriers might be, what do we do about it? And I think that transparency of data is one of the biggest things that can help with patient access. We've certainly seen that in the exchange marketplace with this inaugural launch this year and last year that did not go as well. So here are some ideas. Searchable, transparent formularies. That's one that's really clear. We just did a recent study, and about half of those find it difficult or hard to find the information that they need on an exchange marketplace website. And then I think the others is just transparency around what the actual cost will be. So what tier does my drug sit on? How much does it cost? My out-of-pocket, what is my out-of-pocket? Most of the information on the exchange marketplace is arranged by metal level, so starting with bronze going up. And so most of the people are seeing it that way when they go onto the exchange website. And then detailed information on utilization management and generic substitution policies. I think that gives another transparency to the patient. And the last, which is we're calling for comprehensive out-of-pocket calculators. A lot of those who are in the industry are talking about this. California has a tool out, and there are a couple of others who have sponsored out-of-pocket calculators, which I think will help patients to evaluate from the exchange marketplace. So that's all I have to share with you today. Thank you again for the opportunity to come and speak, and I look forward to panel discussion should we have the time for that.
I'm very honored here today to be able to introduce Representative Marino, who's going to share his personal story about access to specialists. Thank you for coming.
I've been asked to speak about my personal experiences, my daughter's experiences, and my family's experiences concerning the Affordable Care Act or Obamacare, whatever you want to refer to it as. When I was in law school many years ago, 1987, and my constitutional law professor said to us, "Tell us what you think should be a constitutional right." And the typical answers from the students were, and I was not a typical student. I didn't start college until I was 30, so I was like 33 before I got into law school. But it was Second Amendment rights, free speech, right to an attorney. And I did a lot of work in the area of AIDS throughout my life. I've had some friends that passed away from it, and I raised my hand and I said, everyone should have health care in this country, even though they cannot afford it. And it really took the professor back. And I'm a fiscal conservative, I'm a social moderate, and the professor was quite a bit left to me, and she was shocked that I said that. And I didn't ask her why, but she was obviously shocked that I said that because then she finally pulled me aside and said, why? I said, because I've seen too many people die, particularly of AIDS, who were just not treated. They didn't have the money. They were not treated. So we have a responsibility in this country to help those that cannot afford health care. That's a no-brainer. I don't think anybody should argue with that. I'm a big supporter of the National Institute of Health, and I'll tell you why. I have an ulterior motive here, but I was always a supporter of NIH. My daughter has cystic fibrosis. It's a disease for which there's no cure. She's 19 years old now. We found it when she was about 3 months old. And the average lifespan now is it's increasing every couple of years. There's some great work being done in the industry, but now they're telling us it's high 20s, early 30s. But there's some great work that's being done out there. And by the way, my daughter she's a pre-med student at the University of Pittsburgh, and primarily because she wants to do research on rare diseases. But I tell you that because I don't want you to think that, he's a Republican standing up here, so it's going to be, we don't want Obamacare, get rid of it. Well, I have to tell you, admittedly, I voted to repeal it, and I'm going to tell you why. Because I don't think it was thought out. I think the fact that everyone should have health care is what we should be striving for, but it just wasn't thought out, and I'm going to explain to you why. My wife has managed a physician's office for years. I know the law, particularly on these issues, and I follow it quite closely. And the trouble that we had, for example, when I had to sign up for the Affordable Care Act, I was told I had to sign up here in D.C. Well, we went through all the hoops and signed up, and then I get a letter back saying, you don't live in D.C. You can't sign up here, and therefore you don't qualify. So there was a woman in the insurance office that I went to with my chief, and she was very helpful. But she says, we're getting a lot of this, and we don't know why. So I contact the D.C. people and say, I know I don't live here. I live in Williamsport, Pennsylvania. I'm a representative, but because I work here, I have to go into this exchange. And there was a little argument, and then finally when I got the call back, she didn't necessarily say, you're right, but she said, we have to do it this way. And my wife, working in a physician's office, has worked with insurance companies forever. And my wife knows how to work it with the insurance companies, because there are in some situations where many people are told no right off the bat, and they never appeal it or go back and refile the claim. Well, what my wife has done pursuant to my daughter is, when we signed my daughter up, tried to sign my daughter up, it was, she doesn't qualify. She has a pre-existing condition. And I said, wait a minute. Let's stop the bus right here. That is the number one, probably, the first commandment of this is pre-existing conditions should not matter. I have a pre-existing condition. I have kidney cancer, and I'm down to 1/2 of one kidney. And so I've had surgeries over the years. And when it came time to qualify or get into the exchange, I live in Williamsport, but my surgeries were done in Cleveland, Ohio, at the Cleveland Clinic. So we get the information back. Again, sorry, you don't qualify in Pennsylvania. You have to go to Ohio. I said, I don't live in Ohio. That's where I have my surgery done. And because it's one of the leading places on it. Well, the point I'm trying to get across is the left hand didn't know what the right hand was doing. The motive was lofty, but nobody seemed to talk with anyone about the rollout of the program. My daughter is it took us about 8 months, and thank goodness for people at the insurance company and people here in D.C. helped us at least get it somewhat squared away for my daughter, but we still run into many problems with it. My daughter is at the University of Pittsburgh, and she's on insulin. Well, she was home for a break, so she went to our pharmacist and to get her insulin for the break. Pharmacist is putting stuff together, gets a call from the insurance company, gets a call back from the exchange saying she has to go to Pittsburgh to get her prescription. So my daughter and my wife and I were working through this process. Well, it took us so long to work through the process. By the time it was approved, my daughter was back in Pittsburgh. So you know what's coming here, don't you? So my daughter goes to the pharmacist in Pittsburgh and says, look, I ordered this back in Williamsport, but it took so long because the exchange was a problem. And Pittsburgh says, no, you got to go back to Williamsport. So again, my wife's on the phone. She's the brains of the outfit, and she knows what's going on, and she figures all this out. The point I'm trying to get across is just think about the families that the wife or the husband doesn't work in a doctor's office, doesn't know the insurance, does not know the law, does not have a computer to sign up, and they file, and the insurance company and the exchange says no. So what do? They do not know what to do, and my office has had numerous calls, hundreds if not thousands of calls of people saying, I tried this, I called, I waited, and just as recently as this week, people are saying, I still cannot get into this, or they're saying I'm not covered for a major portion of this because of this disease or my daughter's disease or my baby has to go to the hospital. And this is very disheartening because there are more people out there that do not know the system or know what my wife knows and who to contact. And so where are they? They're left in limbo. Now, once again, I worked in industry before I went to college and law school. I worked in a factory, started sweeping floors, and then worked my way up to mid-level management. And I got to a point where I was helping build factories. and which I thought was just common sense, introduced a novel idea because the cost of the cost of building the plant and then rebuilding the plant was so expensive. And I asked, why are you rebuilding the plant? And I finally figured it out. The engineers and the architects and the managers would sit in a room and figure out, okay, this is how we're going to build this plant. But you know what they never talked to? They never talked to people in other plants that ran the machinery, that did work on the floor, the shipping guy who's running a truck around the place. They didn't get any information from them on where to put this button, or where to set this machine, or where to set this area of between shipping and manufacturing. So I brought these people in, and you know something? The cost of rebuilding went away, because I brought experienced people in that actually do the frontline work, and then of course the engineers and the architects. This is what I think the Affordable Care Act missed completely. Bringing in experts, physicians, nurses, hospitals, administrators, pharmaceuticals, people like you and me who have pre-existing conditions and what we're faced with. So there just simply has to be changes to improve what is existing. And there's no program that's put together that's perfect right off the bat. And being in an industry, and then I was a prosecutor for 18 years, and when I built a case, you know, it's much different when you try the case than when the case, you know, you go to the murder scene. But you get everything and you put it together, you talk to people, you get information, and you start building a case. I think that is clearly what we are lacking here. And if it weren't for the physicians at University of Pittsburgh Medical Center, where my daughter is going to school, and if it weren't for physicians at Geisinger Medical Center, who took the initiative and said, we don't care what the insurance is going to do, we're going to take care of your daughter, and we're going to talk with one another. So they're on the phone with each other, talking about my daughter's problem, on the phone with the pharmacies, my Williamsport pharmacy, the Pittsburgh pharmacy, they're trying, you know, they talk with the exchange, and we're slowly getting things worked out. There are still hurdles that we have to get over. But again, just think about the people who don't have the wherewithal to do what my wife and I are going through. My constituent problems that we're having. I had a woman who called us on in December of last year and said, I'm going to have a baby in 2 months. I got notice from my insurance company that after the first of the year, I don't have any insurance. They're not paying for my prenatal care, and they're not paying for the delivery of my child. And I'm hearing from people that my costs are going up, or I'm not getting insurance. My deductible has increased significantly. I can afford it. But how about the many, many people that are making $174,500 a year? It's just, they can't afford this. So the experience has not been good, but we have muddled through it. Once again, think back to the people who just do not know how to get through this. So what we need to do is step back from this. We need to bring all the parties involved here, hear what the issues are, and then start addressing them one at a time. And I'm not going to tell you I could have done this any better, but if I were putting a health care program, I would first of all get a group of people, as I expressed to you, and talk to them. And then I would see what the priorities are. And I think the number one priority, as far as I was concerned, and still am, is pre-existing conditions. So let's tackle the pre-existing condition step first. And then let's get that rectified. Let's get that worked out to where people with pre-existing conditions don't have to go through what I did. Then the next step is let's make sure that those that can't afford and do not have insurance are covered. So once we get the pre-existing conditions out of the way, we go to step 2. We work on getting those covered that do not have insurance. And once we're satisfied with the way that is working, we move to step 3. Now let's start moving people who are in an insurance program that they can't be in anymore. I, as a Congress member, I have to go into the health care program, the exchange. There are certain divisions of the government that do not. The executive branch doesn't have to go into it. The judiciary doesn't have to go into it. Some leadership doesn't have to go into it. So I think if we're going to have a level playing field, let's make it level. Let's not, some people are more equal than others. Let's make everyone go into the exchange, or everyone have a choice not to go into the exchange. So this is how I think there would be a smart way to tackle a giant issue such as the health care. So the calls keep coming in about it's too expensive, or I lost my insurance, or the deductible's too high. I had to go for an MRI not too long ago. And again, I'm not in Cleveland doing this, where I used to be doing that when I had to drive there, but I didn't have time, so I did it in my hometown. And the insurance company, they did my MRI, and there was confusion about it, and they said, you had to go to Cleveland to do this, you can't do this here. And I said, why is that? Because number one, my deductible will pay for the MRI and the services provided by the hospital. So I am writing you a check today that has nothing to do basically with my insurance coverage other than me satisfying part of my deductible. So finally I convinced them, once I hand you the check, then okay, and it's not going to bounce, here's my credentials, and I'm not going to bounce a check on you. So that's some of the experience that I've been through personally. I see what my daughter's going through. I was terrified because of the insulin the other day. She ran out of insulin, and she needs it several times a day, and we're taking her to Pittsburgh. But fortunately, you know something? We got out to Pittsburgh, and the pharmacist, I walked in with my daughter, and he said, Chloe, how you doing? So I introduced myself, and I said, we have an issue here. He says, listen, first of all, what does Chloe need? Let's get that squared away, and then we will deal with the issue. So thank goodness the physicians, the nurses that help my daughter, because she's in the hospital 4 or 5 times a year. I can't be in a situation where I'm in Washington or D.C. or Williamsport, Pennsylvania, and my daughter has to go to the hospital in Pittsburgh, and somebody's giving her a rough time about, you know something, you're not covered here, you have to go back to Williamsport. So these are many issues that we have to work out. I still want to end up with saying everyone deserves health care. If you can't afford it, we as Americans have to take care of those individuals.
Lisa is here all the way from California, here for Hill Day for Leukemia Society. So turn it over to you, Lisa.
Thank you. Just push it. As she said, my name is Lisa Lusk, and my story begins in August of 2012. I was planning my wedding for September and working a good job as a certified nursing assistant. And in the beginning of August 2012, I was rushed to the hospital because of an ulcer that burst. So I had to go into emergency surgery, and following the surgery, they found that I had chronic myeloid leukemia. My husband, my only son, and his wife, and my wonderful granddaughter were devastated, not to mention the family I married into. My son lost his dad when he was nine years old, and for us to get this devastating news, I couldn't leave him, at least not now. I'm a survivor more than one way in my life. As of April, last month, 2014, I'm in remission, but we'll have to take the drug. But I will have to take the drug to Cigna for the rest of my life. When I was diagnosed, I didn't have insurance. I had not had health insurance for at least 10 years. So the hospital had to sign me up for a county program for people who don't qualify for Medicaid to receive care. So many jobs I've worked for didn't offer me insurance, and when they did, I couldn't afford the cost of premiums. After a cancer diagnosis, I certainly would not have been able to purchase insurance on my own on the commercial market. Starting January 2014, I was able to qualify for health insurance because of the Affordable Care Act. A few months prior to that, I had heard about Covered California, the state's health exchange. I called a 1-800 number and spoke with a Covered California representative. She took down my information and determined that I qualified for expanded Medicaid, and it's known as Medi-Cal in California. Because of my state's implementation of expanded Medicare as a result of the Affordable Care Act, I was able to obtain a Medi-Cal plan with CalViva. Thankfully, I'm now a patient of a wonderful oncology practice in Fresno, California called CCare. It is the best place to be a part of because the staff is caring and passionate. Also, I'm able to access to life-saving treatment to Cigna, but a month's supply to Cigna costs about over $5,000, and I have to pay a copay for the medication. I volunteer with the Leukemia Lymphoma Society And last May, I was interviewed by the Associated Press, along with the LLS staff, for an article about the high cost of drugs to treat my disease. To be honest, before I got cancer, I didn't really think about the value of having health insurance. My disease and being part of LLS has educated me about how this can impact a person's financial well-being, and I feel extremely lucky that I have access to quality and affordable health care. We all know that a diagnosis of cancer and other chronic illnesses can be very devastating. After innovative therapies like Gleevec were developed to treat CML, the survival rates jumped dramatically and made the disease a manageable one for most people. But all of us with this rare disease will need these life-saving drugs for the rest of our lives. Without access to these drugs, we do not exist for us. How can we celebrate the achievement made in research if some patients don't have access to these new drugs? I received a phone call from a wonderful person with the Leukemia Lymphoma Society one day when I was released after 15 days of being in the hospital. Still very devastated, but when I received the phone call from Bethany, she made me smile and also gave me hope that I was going to beat this. I think if she wasn't in my life, it would have been a lot harder to cope with. You are my friend for life, and I love you for everything you do for me and every other person you have touched. On the plane ride over here from California, I met a man in his 70s. His wife was diagnosed with breast cancer at the same time he was diagnosed with thyroid cancer. Unfortunately, sad to say, he lost his wife. Him, on the other hand, was saved with all the loving and caring people who help support these terrible diseases. We shared tears and laughter of memories of his wife. He really touched my life and my heart when he said that what we do here is remarkable, and he thanked me for being part of the LLS. I will continue being a volunteer and do whatever it takes to help fight these blood cancers for my new friend Bob and his wife and everybody else who has to go through this horrible disease. I enjoy volunteering and being a survivor, and will do whatever it takes to fight for all who is involved and sick. After all the things that had happened, I was still able to get married the following month to the love of my life, and he has stood by me with everything that has been going on. Thank you.
Last, but certainly not least, we're going to talk about some very essential legislation for the rare disease community, perhaps one of those legislative fixes that Representative Marino was speaking about. But we are very fortunate to have Devon from Representative McKinley's office and Adrian from Representative Capp's office, a very bipartisan bill. I'll just turn it over to you, ladies.
We together, our bosses introduced this bill twice now. They did it last Congress, and this was the first bill that my boss wanted to get introduced in the new Congress. HR 460, which is the Patients Access to Treatment Act. For those of you who are not aware, when you go to the pharmacy, you purchase your drugs, and there's different tiers that you would pay in. For generics, a lot of times, for instance, I have a generic drug that I take every day, and it costs me $5 a month. In some cases, you might get a drug that could cost $25 to $75, and then there's the third tier, which can go anywhere between $100 to $250. Then there is this fourth level, which is called the coinsurance model or specialty tier, and up until December, it was on average 25 to 30% of the cost of the drug. So when you have some certain drugs that cost $150,000 a year, you're paying a third of that. That's $50,000 out of your pocket. It's pretty significant. Now what's happening is, like Congressman Marino had said, and as an afterthought, the insurance companies are not entirely blameless in this situation, but what's happening now that we're discovering is some of the insurance on the exchanges are saying that they don't cover specialty drugs at all. So it doesn't come under this new magic number of a max out for a family of $12,000 a year because it's not covered under their plan. And they're saying the consumer goes in there and chooses that plan without the specialty drugs. I would argue, who knows to look for that? Am I right?
Yeah, I mean, you would know because you're already on it. But if you don't know, you don't plan for the worst when you don't even think of what the worst might be.
So one of the things that both of our bosses talk about is that this is something that, consumers aren't even aware that this is happening. So what our legislation does is it removes the specialty coinsurance tier and requires specialty drugs to be covered under the other tiers. And the insurance companies are saying that this will be an extreme expense. Well, what an Avalair study showed us is that it can be anywhere between $7 and $11 per year per premium. So what that says to me is the insurance that I have with my husband, and I will admit, like I was saying earlier, I got married in November, and we were originally going to get married in February, but I didn't want to go on the exchange. So I'm on his insurance plan, but yeah, I'm an ACA bride. So it increases our insurance plan by $11 a year. To be honest with you, I don't think we'd even notice because all insurance goes up every year. We all experience that, and you don't really know why. And they always say, well, new regulations came into effect, and so everything. So you wouldn't even realize what was going on. The kicker to all of this is we don't have to do legislation in order for this to happen. Medicare created the coinsurance model. I don't know exactly what year it happened, but Medicare created it. And then the private insurance market followed. This came right around the time that biologics were coming into the space, and they are very expensive drugs. You see things, there's a golf pro who's on Humira or something like that. That drug is $75,000 a year. It's not cheap, and the reason is that a biologic is not created like a synthetic. It's not a pill, it's an injectable, and it's created from human plasma. So you first have to get someone to donate their blood, you have to strip it, get the plasma, and then you combine it with the drugs it's an injectable into the person's system. It's not a simple thing. Yes, when it goes generic, it'll come down a little bit, but the estimates are about 20%. So it's still going to be an incredibly expensive drug. And I'll kind of end with this last statement about, so one of the things that with our bill is that it comes out as budget neutral because it's a mandate on the private market. So the government doesn't have anything to cost for it. My boss has been arguing the last couple months that this would actually produce a savings for the government because these people are now not going to go on Social Security disability and end up on Medicare. And they are working and paying taxes. So if we keep them healthy, we save money. And that's what he's been arguing. So now I'll turn it over to Adrienne.
Sure. So, hi, Adrienne Castelletti. I work for Congressman Lois Capps, and she's a nurse from the Central Coast of California, actually. And for her, having worked in the healthcare space her entire life, she knows that, the insurance companies have found ways to be profitable in business, and that's great. But what we know is in some states, they've already done this, and it hasn't caused any problems. Like New York has already done this. We know that for $7, so in DC, a very expensive place, a glass of wine, a beer, for your whole year can help ensure that if you get sick, you can have access to the medications that you need, and that your neighbor who already might be sick has access to the medications that they need. One of the amazing as people have now been able to get health insurance that oftentimes couldn't before, these are the same folks who need these specialty tier drugs. So, now that there's no more pre-existing conditions, exclusions, and we held the insurance companies accountable a lot in the Affordable Care Act, we now need to make sure that when people have that insurance and have that private insurance and buy into our private market system that we've always had and that we're building upon, that people can actually get the care that they need and deserve. One thing to highlight about this bill that I think is really important is the wide variety of folks who are supporting it. And I think that kind of stems from the fact that it touches so many different folks, so many different disease groups, which no offense, we would expect, right? People know what's going on with their patients, and their patients tell them this is the problem, and they want to keep moving. But we have so many of the actual pharmaceutical and pharmaceutical companies who are also involved in this because they know that they have these products and they want to get it to the patients that need them. So when you have kind of that sort of wraparound advocacy arm, it really helps push an issue forward. And I think that's why you have 108 co-sponsors now, very bipartisan in this kind of Congress. Those are really good numbers. And I think that's because of the impact that folks like you, folks like you, and folks like you will be later today, hopefully, will have by advocating for this bill.
To kind of follow on to what Adrian said, if the drug companies aren't going to be able to sell their drugs, these new specialty drugs, because they're not being covered, what is going to push them into getting to the next generation? What is going to promote them to innovate? This, if we don't encourage people the access that they need, we're going to stifle innovation. Congressman Marino talked about NIH. Why would NIH invest in something that no one's going to be able to, in the long run, buy? My boss is a huge supporter of NIH. It always shocks everybody. He's a Tea Party Republican, and he introduced this bill. But it's not about, Republican or Democrat. This is a bipartisan bill, and we're going to add another 3 co-sponsors today. It's about getting people the care that they need. Just the bottom line.
And thank you all so much for coming today. Thank you to our sponsors, Shire and Vertex, and NORD and Leukemia and Lymphoma Society for joining us today. Thank you.